Good morning, everyone. I'd like to welcome you to New Brunswick Lung NB Lung's 31st Annual Respiratory Health Symposium.
Our first speaker this morning is Daniel Landry, who has BSc in Pharm and Regional Coordinator at Antimicrobial Stewardship Program. Dan Landry graduated from Dalhousie University College in 2009. With experience first in the community setting, he began practicing as a hospital pharmacist in 2013 at the Dr. George L. Dumont University Hospital Center in Brunswick. In 2015, he started his current practice as an infectious diseases antimicrobial stewardship pharmacist at the Multiple Society. In recent years, his role has shifted to serving as the regional coordinator of the Palisade Health Network Antimicrobial Stewardship Program as they work to establish services in the health authority's various hospitals across the province. He's also a core member of the New Brunswick Provincial Antimicrobial Stewardship Committee, where he helped develop provincial AMS initiatives, such as the management of patients reporting penicillin allergy and the development of treatment guidelines to assist clinicians. This morning, he will be speaking about RSV, reducing suffering associated with RSV. So I would like to now welcome Dan. Thank you, Dan.
All right, thanks for the introduction. And yeah, sorry that I know antimicrobial stewardship for me is pretty easy to say, but for other people, it's not something you tend to use on a day-to-day basis. I'm just going to share my screen, and just as a heads up for everyone, I am going to be speaking in French. So if you want to get the interpretation ready to go. So I'll start with that right now. So merci de m'inviter ici aujourd'hui. Je réalise maintenant que le titre est
I realize now that this is much more fun for me in French. In English, we talk about RSR, and in French we have VRS. So if you ask a hospital pharmacist, when we talk about VRS prevention, I can see the consequences of this disease, and that's why I want to minimize the impact of this disease. Now, housekeeping acknowledgement, I got many presentations by Baxter, the ones that are listed in here, also from Seqirus. I do not recommend a brand as opposed to any other one. They're all deemed to be equivalent and interchangeable. It is possible that I'll be mentioning commercial brand names for vaccines, but the generic brands are totally very similar. As I said, I might be using commercial words as opposed to generic. They're so similar. You might confuse them from one for the other anyway. So today's objective is to review with 30 minutes, I don't have time to go into details with this. I might say RSV in French every now and then. Excuse me, sometimes if I say, I use the French acronym and so on and so forth. So we want to appreciate the burden that RSV may represent in the newborn and older people. We have to determine the risk factors in terms of hospitalization, death, and which are secondary to RSV. And we will review the recommendations of the NACI for the prevention of the RSV. So, RSV traditionally has been basically ignored because we give all of the attention to influenza and COVID. Obviously, they are problems. They're very important, problems, and they need our attention. But RSV has almost been omitted, basically by just about everybody. And I want to make people aware that there is something that RSV is a very common respiratory virus. It's a non-complete immunity. You get reinfected all along your life, and it's transmitted only from human to humans. And basically, all children are infected before they reach the age of 2. So basically, everybody's going to get it. Transmission. We saw throughout the COVID, especially at the beginning, the RSV was totally ignored, but usually we deal with it, when the flu season shows up. Transmission, as I said, it can be small drops, contact, and or a spray. Maybe people were not as aware of what this was all about before COVID, but now many groups are in the process of mentioning what the viruses are all about. So the initial clinical presentation of the RSV is rather similar to other viruses that we'll be talking about. By the way, I thought I would say that the diseases are the same. That's not what I'm saying. Obviously, there are peculiarities for each and every, or specificities for each and one. But basically, at the outset, you can't really tell the difference between the flu, the RSV, and COVID. And if you don't proceed with the test, here at Georges Dumont, some of my colleagues and I were pretty sure that we had the flu, and it turns out that we had COVID. So, and sometimes we think it's COVID, and then we have a RSV. So, you're fatigued, wheezing, congested nose, and so on and so forth. So you might be losing your taste, that sort of a thing. When you read all of this, you see that the symptoms are likely to all of the three of them. With the flu, the myalgia seems to be more prevalent with the flu. We have more wheezing with the RSV. And, it's rather classic with COVID as well, but it doesn't have to be too bad. I just wanted to mention these things because we most likely have seen too much. Well, we've seen more RSV than we think. Before, we didn't test for that. Now that we have more testing, especially at hospital level, before it was to be called an influenza-like illness, or we thought it was a problem with a newborn only. Here, we as professionals, if you get a test, it will not change your behavior. We didn't have any treatment to offer to our patients before. So it probably has influenced the fact that we were not testing before, at least not enough. So what is the burden of this disease? And now for children, and I'm talking young, those that are less than 5 years of age, and especially those that are less than 12 months, the burden is much more than influenza. I'm convinced that many people are not aware of this fact. RSV is responsible for about a third of the pneumonias within kids in the world. More than 1.3 million people have to go to hospital around the world, and we lose 118,000 people to it. Within Canada, we have 5% of children who get to be hospitalized, and they need intensive care. And the mortality rate, however, is fairly low. It's not major, but we're talking 0.1%. COVID-wise, we heard, we're talking about mobility, vulnerable people within the hospital. But with RSV in children, majority of children don't have comorbidity. We're talking about premature kids, they're more at risk. But are we really looking at the number of children? Most of them don't have morbidity to mention of. So for aged or older people, the 60 and over, we're talking about 8% of all the respiratory infections are need to necessitate medical visits, and 43.7% of 1,000 need to go to the hospital. 88.6 out of 100,000 for those who are 70 and over, and 282,000, 80%, 80 plus go to the hospital. 10% have to visit a hospital because of RSV, and 9 to 10% die of RSV. So to summarize, hospitalization and RSV, we're talking less than 5 years old, 7 out of 10 of people who go to the hospitals are kids. Now the death, we're talking the 65 and over, 85% of them will represent the deaths. Okay. So the 60, as I said, the 65 and over represent. It depends on the population here with the spectrum. Okay, we see bronchitis, we see a cold. Sometimes we see otitis. Sometimes we see bronchiolitis, pneumonia, and we're talking of those that are less than 6 months. So, not everybody that's 60 and over needs a cane, but I needed an icon, so I'm sorry, I don't mean to be prejudiced here. Now, for adults, we thought they were all part of the RSV because of, I've seen pneumonia, bronchitis, cold as well, and the asthma is exacerbated, and COPD is also exacerbated. So, if you have heart problems, it may exacerbate some of your problems. Why with them more than others? Because their immune system is, especially with children, they're not mature enough to have a proper immune system. Now, the maternal antibodies are on the way down. Over time, the system could not really deal with this upcoming, and sometimes the respiratory system is too small, and they cannot clear their own mucus. So now, in older people, the system is not as capable of dealing with infection. So the lungs are not as elastic, and they cannot get rid of their phlegm as easily as they would normally do. So we're beginning at that point to accumulate morbidity as we grow older in life. And this comorbidity will create possibilities of an increase of getting sick. Now, RSV can reduce the functional status of a person. We're saying what happens with people who are released from the hospital after 6 months? They've been released from the hospital after 6 months. What happens, right? So what happens before they're hospitalized? 40% of them stay at home, 50% get help from the community with some assistance, and 8% need to go to a nursing home or in a nursing home. Now, after 6 months, 1 patient out of 3 has a functional status that is reduced, 8% less of those who live at home. Now, less than 6 months or plus or less prematurity and complications. That's a factor of risk. Also, if you are older than 70, you may have your increased factors as well. We see extremes getting affected. Well, your socioeconomic status as well. When you take your test socially, you see at those who have more and more RSV, those countries where there is poverty, increased poverty. Now, tobacco use, of course, you know, so we need to work on smoking cessation. Now, nursing homes, wherever you get care, risk is increased by four times. Now, comorbidities, COPD, heart diseases, immunosuppression, diabetes, kidney insufficiency, and lung disease and asthma. So how do you prevent RSV? I like this part here. Somebody said the best treatment for illness is not to have it in the first place.
Instead of putting ambulances at the bottom of the
cliff, we should be putting a fence at the top instead. And Dr. McGeer says that we shouldn't wait something to become a problem. Oops. Two people talk at the same time. I'm sorry here. I like my analogy. The one I use is this. Okay. When there is a flood coming up, don't wait until the house is underwater to put your sandbags at the door. Set your sandbags first. You don't want to wait for catastrophes to deal with such problems. So there are two things we can prevent RSV with newborn. We can use near-70 a unique dose. Let me say this, that it replaces the Synagis. This one works on a longer period. And we also have a vaccine. That it is to be used during pregnancy. So the mother antibodies act on the child before he's born. So there's been a revision in 2024 on this. Now, the nirsevimab, it will last at least 150 days, but it's supposed to be effective for at least 8 months. Now, that's to keep the baby, until he's 10, where the immunity system is a bit more strong. Now, when you use it, the intensive care requirements are way down because the efficacy is 90%. Visits are as well down. So we see that the efficiency of that product is quite good, and there is no difference in side effects. Of course, there is a very efficient intervention here. Now, the pre-F RSV, that is, one dose during pregnancy. They haven't been able to tell statistically significant here. We see the interval here is at 80%. Why? Because the number of events was very low. Oh, why? The study was done in 2020 to 2022. And back then, there was a whole lot less RSV. And COVID was the star at that point, right? So we didn't have enough data to make a statement on it. Hospitalization, the interval was 10 to 81%, but statistically, we only had 7 cases, and the medical visits efficiency was 51%. So the interval, kind of narrows at that point. Now, in terms of some side effects, pain in the shoulder, that sort of thing. We saw that in premature birth, but it wasn't significant because it was only limited to one country. The real world study showed that it doesn't seem to be a problem anywhere. In Canada, it would seem that there was no abundance, and they decided to stretch over the week to, we've seen one time where the RSV may have caused a premature. So premature birth, that sort of a thing. So what do we recommend for newborns? You have to put an immunization program, a universal one for all newborn. We recommend immunization program using nirsevimab to prevent severe diseases that will be caused by the RSV. You know, it's an individual decision, and you need to discuss that with your patient. You don't, you know, price availability. You need to discuss which vaccine you were using, that sort of a thing. But we do not recommend a vaccination program because it's not ready for the moment. Now, for older people, we have two options, two vaccines, RSV.
Celui-ci a un adjuvant qui est inclus, puis c'est le même adjuvant qu'on voit dans le
It has an adjuvant with it, and it's the same one you see in the shingles, in the Shingrix, but it's only a half dose. And the other one, the RSV, does not have an adjuvant.
Éventuellement, on aura un vaccin ARNM.
And eventually, we'll probably have an ARNM. Moderna is focusing on that one right now. It's available in the States, but not in Canada. And NACI is going to come up with something this summer. Now we've studied the VRS-3, RSV, that means. And so disease in the respiratory tract is lower. Low interval is 58 to 94. Severe LRTD interval was 62 to basically 100, but we were incapable of evaluating the hospitalizations or the intensive care. That was done through 3 seasons between 21 and 24. Now, in terms of is it tolerable? You know, side effects, local pain. We see different, you know, it's usually light to moderate pain. Let's say if anything could endanger life, there was not really. But you shouldn't be surprised to see that when you had an adjuvant, that's already known, be used in something else. Of course, it creates local pain type of thing. Now, with those without the adjuvant, we can see they couldn't evaluate the hospitalizations and the intensive care. You'll see that the rates are not the same. We cannot one against the other because the definitions are not the same. The studies were separate, and it's important as well to take that into consideration because when you want to look at the side effects, they're not as severe with the second possibility. My opinion, however, is that it makes sense to have less, you know, side effects if you don't have an adjuvant. But you know, in terms of that's just an opinion. Because if you look at the confidence interval, well, now the NACI recommends vaccination program for adults 65 and over, especially for those who have heart problems, lung problems, 60 and over who live in nursing homes or residences for older people, you know, should be vaccinated as well. And everybody else, 60 to 74, are at risk. Well, you have to make individual decisions, okay? In the States, there was a recommendation that it's rather recent. They made observational studies. It's not randomized, however, but the reason why it's important here is the randomized studies will show you different levels of immunosuppression. Almost 15% here. 1 out of 3 have 4 comorbidities and over. So, you know, because this is only observation and I don't have much time, I cannot go through all of the details. It still shows fairly clearly that these vaccines can reduce the risks to have to go to the hospitals or severe outcomes afterwards. In the States, they updated their recommendations. Now they recommend. They don't. It's not only considerations. Now they're talking recommendations of a single dose for anyone that is over 75. Those that have high risk between 60 and 74 should also have one dose. Now, New Brunswick reimburses, and it's the first time that they reimburse, but only for those who are in nursing homes. And those are in hospitals are waiting nursing care in a nursing home. So it does, do you have to have a second shot? Well, some people say it's not important. Well, what is the province saying? Before I go to the next slide, I might add here. Some people think that cost is the main obstacle to vaccination. So studies show us that people say that they just don't have a recommendation for their provider. Patients trust us, but we think it's a good idea to recommend. In terms of what happens in terms of the province itself, we cannot decide for them. We can only recommend. We can talk to our patients about it. One thing we need to remember, let's stop thinking that RSV is just something that happens to older adults. It is not. It is just not a cold. Before I go to questions, again, it's not just a cold. You might get hospitalized, and it represents a lot of deaths in terms of very older people, such as in flu, such as COVID. RSV is not just a viral infection. You can get extra pulmonary difficulties. We're talking your heart. You're talking about all kinds of problems. If you're 70 and over, you're more at risk. And comorbidities will drastically increase within certain populations. And we can protect our vulnerable populations from this disease. There is a treatment. The best one is not to get it. Therefore, is to prevent it. Now, for newborn, we don't have anything formal in New Brunswick for the time being. I hope that something is going to come up soon. And for older people, 60 and over, in nursing homes in New Brunswick, there's a program to reimburse. But those who have comorbidities, if you are 70 and over, generally speaking, my opinion is that we should, especially if they have specific comorbidities, we should engage these patients. And one last thing, in New Brunswick, pharmacists cannot prescribe medication against RSV. So, it's the same as COVID. Things should change soon. We're trying to review this as a group, and we hope that things will change soon. I believe that I have 5 minutes left for questions. I'll give you the microphone. Questions, English or French?
Thank you, Dan. I'm not seeing any questions in there now, but I would like to know if you guys can hear me better now, because we have done some technical changes. Yes, do apologize for that. We're having a few glitches this morning, but I think that our guys have got it all figured out. So if anybody has questions, you can pop them in now. I'm not seeing any so far.
I can, in the absence of questions, I had decided to remove a few slides. So if I don't see any popping up, please stop me if at any point, but I'll just, go ahead. Then. It's kind of awkward for me to have French. I'll just speak in English for now. So we have observational studies that some people might say, oh, there's Guillain-Barré syndrome is a risk. And there was this, numerical but not statistically significant increase of Guillain-Barré syndrome. but these are relative numbers. They're not significant. And it's important to note that background rates of GBS is 0.62 to 2.6 per 100,000 patient years. So very rare problem. And when ACIP looked at this, they actually took these as gold, even though they shouldn't do that, but they took it as a worst case scenario. And they showed that the overwhelming benefits certainly outweigh the theoretical risk.
We do actually have a couple of questions now too, Dan.
Okay.
I'm sorry, I don't want to interrupt you.
No, please interrupt. That's what I had those for, as place fillers.
Yes, great. So I'm going to give you both questions and then you can answer them. The first question is, could you clarify what the coverage is for RSV vaccination in New Brunswick? And the second question is, do you recommend hospitalized elderly also get vaccinated?
So the coverage in New Brunswick is anybody 60 plus who's living in a long-term care setting. So nursing home, special care home, such like that. And anyone who is 60 plus, hospitalized, but at an alternate level of care, i.e. they're waiting for placement in a long-term care home. So it's basically long-term care home 60 plus that would be paid for by the province. As far as the question for hospitalized elderly, certainly anybody who's alternate level of care, yes. So meaning they're waiting for a placement, that fits in these criteria, and I'd certainly recommend it. As far as hospitalized elderly that are not alternate level of care, but are there for other reasons, it depends on why they're there. I mean, if they're there for septic shock, I probably wouldn't vaccinate them on the spot when they're there with sepsis. But if they're there for a hip fracture and they're just doing rehab, then certainly I think it would be a good idea. The problem is in the hospital, it wouldn't be on formulary. So it would technically be up to the family to get it in community, bring it in and get them vaccinated. Completely okay with that. I don't want people to decide for the family or the patient that it's not possible without asking them. But the acute care elderly in the hospital is not always straightforward. It's very case by case as far as doing it right there and then in the hospital. But it also might be to mention it to them and discuss with them and have their family physician kind of follow up. Should Horizon look at changing that policy? That is, it's just any non-formulary agents. They have had that policy for a long time. It doesn't just apply to vaccines. And I'm not gonna, Horizon and Vitality both have the same one. And it's for any non-form drugs. And it's more of it's not a topic that I want to get into, but I would be quite confident in saying it's not going to happen for something like this. Non-formulary requests can be done. It doesn't mean it's going to be approved though. And I would be surprised if it would be addressed because it also applies to other molecules that would be used for treatment that wouldn't be on the formulary. So they generally don't have much wiggle room for that, but I also don't want to say yes or no because it's not my call to make. So
great. We're getting more questions now. So we have a couple minutes left, or about 1 or 2 minutes left. So the last questions are, what is the cost to get it if it's not funded for those over 60? And my added part to that would be, do most private care, private providers cover that? And then how long does immunity last and how often would you need for a booster?
So don't quote me on the price because I don't know it off the top of my head. We don't dispense it in the hospital and we're not a community pharmacy, but I believe it's in the ballpark of $300 to $400. I'm not sure, it might be less, but I know it's for sure more than 200. But don't quote me on the price exactly. There was some discussion on price in the NACI guidelines, so I'm not sure where that is, but it's a few $100s for sure. Efficacy is at least 2 years. We don't know if it's 3 or not. The studies are currently being finalized for the duration, but it's minimum 2 years. So right now they're covering 1 dose and they're kind of going to reevaluate when the boosters would be. But for the moment, we know for sure that protection lasts at least 2 years. And we'll probably see more data coming out shortly for 18 plus immunosuppressed. We just don't have the studies being done. But I see for time, I think I'm done. So if anybody has any questions, reach out to me. Happy to talk outside the.
Thank you. Thank you so much for that information and for your presentation and for being able to get those questions filled out quickly there. Thank you.